Epiglottitis. Introduction. The epiglottis is flap of cartilage located in the throat behind the tongue and in front of the larynx. The epiglottis is usually upright at rest, allowing air to pass into the larynx and lungs. When a person swallows, the epiglottis folds backward to cover the entrance of the larynx so food and liquid do not enter the windpipe and lungs. After swallowing, the epiglottis returns to its original upright position. Definition. Epiglottitis is a potentially life-threatening condition that occurs when the epiglottis, a small cartilage lid that covers windpipe, swells, blocking the flow of air into lungs. Epiglottitis is a rapidly progressive bacterial infection of the epiglottis and surrounding tissues that may lead to sudden respiratory obstruction and death. Symptoms include severe sore throat, dysphagia, high fever, drooling, and inspiratory stridor. Epiglottitis, also termed supraglottitis or epiglottitis, is an inflammation of structures above the insertion of the glottis and is most often caused by bacterial infection. Risk factors. Age. Children younger than 12 months of age are at a higher risk for developing epiglottitis. This is because these children haven't yet completed the Hib vaccine series. Overall, the disease commonly occurs in children ages 2 to 6 years. For adults, being older than 85 years is a risk factor. Sex. Males are more likely to develop epiglottitis than females. The reason for this is unclear. Environment. Heavily populated environments such as schools or child care centers may increase clients' exposure to all types of respiratory infections. The risk of getting epiglottitis is increased in those environments. Weak immune system. A weakened immune system can make it more difficult for body to fight infections. Poor immune function makes it easier for epiglottitis to develop. Having diabetes has been shown to be a risk factor in adults. Causes. Haemophilus influenzae type B, epiglottitis most often affects children 2 to 7 years. Haemophilus influenzae. Historically, Haemophilus influenzae type B, Hib, was the most common strain of bacteria that causes this condition is Haemophilus commonly caused by predominant organism, 90%, in pediatric epiglottitis cases. Streptococcus pneumoniae. Viral agents. Although viruses normally do not cause epiglottitis, a previous viral infection may allow bacterial superinfection to occur. Viral agents may include herpes simplex virus, HSV, parainfluenzae virus, varicella zoster virus, VZV, human immunodeficiency virus, HIV, and Epstein-Barr virus, EBV. Varicella can cause a primary or secondary infection, often with group A beta hemolytic streptococci. Non-infectious causes. Non-infectious etiologies include thermal injuries, trauma causing blind finger sweeps to remove a foreign body from the pharynx, angionephrotic edema, hemophagocytic lymphohistiocytosis, and acute leukemia. Pathophysiology. Haemophilus influenzae type B, Hib, or Streptococcus pneumoniae can colonize the pharynges of otherwise healthy children through respiratory transmission from intimate contact. The epiglottis becomes inflamed and swollen with edema. Hib infection of the epiglottis leads to acute onset of inflammatory edema, beginning on the lingual surface of the epiglottis where the submucosa is loosely attached. Swelling significantly reduces the airway aperture. Edema rapidly progresses to involve the aryepiglottic folds, the arytenoids, and the entire supraglottic larynx. The tightly bound epithelium on the vocal cords halts edema spread at this level. Frank airway obstruction, aspiration of oropharyngeal secretions, or distal mucus plugging can cause respiratory arrest. Clinical manifestations. The symptoms of epiglottitis that are common in children include a high fever, lessened symptoms when leaning forward or sitting upright, sore throat, a hoarse voice, drooling, difficulty swallowing, dysphagia, painful swallowing, odinophagia, restlessness, breathing through mouth. Symptoms common in adults include fever, difficulty breathing, difficulty swallowing, a raspy or muffled voice, harsh, Noisy breathing. A severe sore throat. An inability to catch their breath. If epiglottitis is untreated, it can block airway completely. This can lead to bluish discoloration of skin due to lack of oxygen. This is a critical condition and requires immediate medical attention. Diagnosis. Due to the seriousness of this condition, client may receive a diagnosis in an emergency care setting simply by physical observations and a medical history. History taking. Take history regarding past illness, surgery, personal habit, dietary history, onset of symptoms. Physical examination. Breathing difficulty, hoarseness of voice, dysphagia, dysphasia, odynophagia, cyanosis, sore throat. Throat examination. Using a flexible fiber optic lighted tube, the doctor may look down child's throat to see what's causing the symptoms. A local anesthetic can help relieve any discomfort. Chest or neck X-ray. Because of the danger of sudden breathing problems, children may have X-rays taken at their bedsides rather than in the radiology department, but only after the airway is protected. With epiglottitis, the X-ray may reveal what looks like a thumbprint in the neck, an indication of an enlarged epiglottis. Throat culture and blood tests. For the culture, the epiglottis is wiped with a cotton swab and the tissue sample is checked for Hib. Blood cultures are usually taken because bacteremia, a severe bloodstream infection, may accompany epiglottitis. Management. Treatment in patients with epiglottitis is directed toward relieving the airway obstruction and eradicating the infectious agent. Manage respiratory arrest. When a child has respiratory arrest, the first step is to administer bag-valve mask ventilation with 100% oxygen. Once the child is oxygenated and ventilated, the airway can be secured with an endotracheal tube, cricothyrotomy, or tracheostomy. These treatments should prevent cerebral anoxia, arrest, and death, the most feared complications. Moist air administration. Moist air is necessary to help reduce the inflammation of the epiglottitis. Pulse oximetry. Pulse oximetry is required to monitor oxygen requirements. Endotracheal intubation. Once supplemental oxygen is provided, the next crucial step is to mobilize a team to establish an appropriate airway via endotracheal intubation. Mortality rates for children who receive endotracheal intubation are less than 1%. Children who do not receive intubation have mortality rates as high as 10%. Tracheostomy. If endotracheal intubation is unsuccessful, perform a tracheostomy with percutaneous translaryngeal ventilation used as a temporizing measure. Pharmacologic management. Medications used for a child with epiglottitis are antibiotics. Appropriate antibiotics include ceftriaxone, cefotaxime, and cefuroxime for non-meningitic infections, as in all invasive Haemophilus influenzae type B, Hib, infections. Contacts should receive rifampin chemoprophylaxis. For epiglottitis due to other organisms, antibiotics should be tailored to the cause of the infection. Corticosteroids. Corticosteroid administration, although advocated in the past based on anecdotal reports, remains controversial. E.g. dexamethasone, prednisolone, Budecort. Nursing management. Nursing assessment. Assessing a child with epiglottitis should include respiratory assessment. Assess the child's breathing, any history of injury to the throat, breathing through the mouth, stridor, and hypoxia. Cardiovascular assessment. Assess the child's pulse, assess for tachycardia and a thready pulse. Gastrointestinal assessment. Assess if there is an inability to swallow. Nursing diagnosis. Based on the assessment data, the major nursing diagnoses are ineffective breathing pattern related to upper airway edema, anxiety related to respiratory distress, hyperthermia related to inflammatory process, deficient knowledge related to lack of knowledge on the disease process. Nursing care planning and goals. The major goals are: patient and family will verbalize strategies to reduce anxiety. Patient and family will demonstrate an understanding of what has been taught. Patient and family will verbalize understanding of condition, disease process and treatment. The patient's temperature will be within normal range. The patient will maintain adequate ventilation and oxygenation. The patient will maintain a patent airway. Nursing interventions. The nursing interventions for a child with epiglottitis are: anxiety control. The child and the family should display personal actions to eliminate or reduce feelings of apprehension and tension from an unidentifiable source. Learning facilitation. The nurse should promote the ability to process and comprehend information, and encourage improvement of the ability and willingness to receive information. Medications. Administer antibiotics as prescribed, such as sfuroxime. Hydration. Regulate for fluid accordingly, since the child could not swallow. Evaluation. Goals are met as evidenced by patient and family verbalized strategies to reduce anxiety. Patient and family demonstrated an understanding of what has been taught. Patient and family verbalized understanding of condition, disease process and treatment. The patient's temperature is within normal range. The patient maintained adequate ventilation and oxygenation. The patient maintained a patent airway. Complications. Epiglottitis can cause a number of complications, including respiratory failure. If the epiglottis becomes swollen, either from infection or from injury, the airway narrows and may become completely blocked. This can lead to respiratory failure, a life-threatening condition in which the level of oxygen in the blood drops dangerously low or the level of carbon dioxide becomes excessively high. Spreading infection. Sometimes the bacteria that cause epiglottitis cause infections elsewhere in the body, such as pneumonia, meningitis or a bloodstream infection.
So guys, thanks for watching my video. You can like and comment on my video, but don't forget to subscribe my YouTube channel to watch quality content like this. Thank you guys.